So there was a whole session today about stopping therapy, and I think it's really starting to become mainstream in practice that people are really starting to think about it. So I think hopefully we will start to see in guidelines in the future potentially suggestions as to which patients might be able to stop therapy, and providing more information for physicians about which patients it's safe to stop. Patients that are selected to stop therapy at the moment are based on the depth of response, and it's those patients that have had a very deep response to therapy and have been on therapy for quite a long time where there's an attempt to stop therapy. In those patients, depending on the drugs that they've had, probably about 50% of the patients have a successful stop of therapy. The other 50% you start to see the leukemia gene coming back and they need to restart therapy. But we know that stopping is safe, and even for those patients where the leukemia gene starts to come back, when they restart therapy they very quickly get it under control. The measurement of the deep response is done by a test called PCR for BCR-ABL, and once that gets down to a very low level or undetectable, then those are the patients that might be considered for stopping therapy. In the clinical trials so far, it has tended to be patients that have been on their first tyrosine kinase inhibitor, and some patients that have had intolerance to therapy. For patients that have been resistant to one of the drugs, most physicians are very reluctant to stop those patients because they're concerned about loss of response. I think there are a few areas at the moment. There's the introduction of generic Imatinib, which has happened in a few countries so far and is becoming increasingly widespread. So I think that's going to change sort of practice for upfront treatment of patients. I think the stopping studies are important, and I think that is going to lead to changes in guidelines in the next few years. And I think the other area that's important that we still need to address is the blast crisis. So that's those patients that progress to an acute leukemia, and we need to develop better treatments for those patients, and also potentially be able to identify those patients at diagnosis so that we can select them for alternative treatment strategies or monitor them more carefully.